All participant cameras, sorry, thank you. All participant cameras and mics will be off. The session's going to be recorded, and if you're not comfortable with that, please do opt out now, and it will be available for you to watch later. At the end of each session, there'll be a short moderated Q&A for you to ask questions. If you use the Q&A tab at the top of the screen, chat is disabled, so it's just a Q&A session. If we don't get to your questions, they will be answered offline and they'll be added to all the shared materials. And also, while we go along, if you can like any of the questions, it gives us an idea of the most popular ones to get answered. All materials and recordings will be uploaded to the website afterwards, and any links to references and resources will be shared in the comment section at the end of the session. So if we go to the next slide. So safe practice, this is the start of the session. It's making sure that whatever we put in is fit for purpose and they're paramount for the safe delivery of care. So there are questions that need to be answered for ICSs and organisations, and also just session questions for organisations. I'm sure a lot of you have looked at what good looks like already, and hopefully this session will give you some of the ideas on how to answer these questions for that assessment that you need to do. So with no further ado, we've still got a few people coming in, which is fantastic. We've got 178 already, which is really good. So to start with, unfortunately, Sandra Carver, who was one of our speakers, due to unforeseen circumstances, can't make it. So I hope all is well with you, Sandra, but we've tried to cover the time and hopefully give you all some more information. So with no further ado, if we can go over to Rudy Redford-Brown and Andy Carr, who are both safety engineer and clinical informatics manager for the clinical safety team at NHS England.
Hi, afternoon everyone. I'm Andy Carr. Go to the next slide, please. Thank you. So Andy Carr has a little bit of background about me on the slide there, but to summarise, I'm a physiotherapist by background. I've been working in the NHS now for 30 years and increasingly in the field of informatics for over 20. My informatics career started in Salford on the electronic patient record team, where I worked for 7 years, and then spent 10 years working as a clinical advisor on the National Summary Care Record, but for the last 7 years been working full-time in the field of clinical safety. And that's me. Rudy, over to you.
Hi, next slide please. I'm Rudy, so I'm a safety engineer. I work alongside Andy in the safety team. So I've worked at NHS England now for about 6 years. I'm non-clinical, so I assure a variety of systems you can see on the slide there. Alongside that though, I'm also the training manager, so that's a huge passion of mine. Some work that we're doing that we'll speak about later on is looking at the train the trainer model. I know there's been some interest in that from you in conversation with Kate earlier. So yeah, looking forward to speaking to everybody and hearing more from you. Next slide, please. Okay, so the big question, what is digital clinical safety? You know, why should we bother is also something that is important to cover here. So I'm sure we all know that health IT and technology is featuring at every point in a patient's NHS and social care journey. The complexity is growing year by year, obviously with AI featuring more and more. It's so important to ensure that the systems we implement don't introduce safety concerns or incidents or issues. So we look to implement clinical risk management principles wherever possible. You can see there the definition of digital clinical safety. Just moving on to a slide that I really like. It's nice and visual. on to our next slide. Thank you. So this slide for me just reiterates how important it is that safety and design should go hand in hand. So partnership and undertaking clinical risk management activities really early and preempting what could go wrong is really important. The preemptive work that we do in a hazard assessment in this scenario, from the images you can see here, might have prevented, you see the second image, of prevented someone ingesting insect spray over cooking spray. So yeah, just a nice visual there. So in terms of expertise and SME knowledge, you're the expert in your area, you know your specialty, you know how staff use the system, and you also know what patients need out of that system. So what we're going to talk about in terms of a clinical risk management process, it's really important that the key people are in there, because if not, you get something, you know, that you can see on here that doesn't work for those using the systems and isn't safe for patients. I'll also speak about with Andy as we go through this, how you can try and embed a safety culture across your organisation, because digital clinical safety isn't the responsibility of one person. So we'll talk about that as we go through. Next slide, please. So I'll just hand over to my colleague Andy just to take you through the standards.
Thanks, Rudy. So yeah, the two clinical risk management standards that underpin all this work are DCB 0129 and DCB 0160, and they've both been mandated for over 10 years now, and it's certainly sort of now getting a lot of traction and people are aware of them across multiple organisations, and many of the suppliers that are in the English health market are very familiar with these and are doing very well at reaching compliance, albeit it's not universal yet. But DCB 0129 is specifically aimed at the manufacturers of those systems who are developing them and also improving and iterating them as time goes on. And DCB 0160 is specifically aimed at any organisation that is critically procuring, implementing, using, or decommissioning those systems. The two standards are very, very straightforward and easy to read. So if you haven't read them, I would strongly advise to do this. That they're very concise. They're very, very concise and clear. You'll find if you look at do a comparison of the two standards, they're both very, very similar to each other. But one key difference that we've called out on this slide is that in DCB 0160, a key requirement is that any organisation that's procuring or implementing a health IT system must ensure that their supplier is compliant with DCB 0129. As I say, the standards themselves are very concise, but sitting alongside those standards, you'll find implementation guidance, which is a really handy reference guide to use to help expand on any areas that you feel need a little bit more detail. And also they've got examples of risk matrices and etc. that can be used alongside them. Next slide, please. So fundamentally, what the standards are trying to make sure happens is ensuring that when anyone is sort of developing or particularly implementing on these systems, they're considering these questions. What could go wrong? If it does go wrong, how bad could it be? And then how likely is it to be that bad? And ultimately, what are we going to do about it? What have we already done about it? What more can we do about it? One more click, please. Now, the standards actually then add a terminology to it. So, you know, it's fairly straightforward stuff there on the left-hand side. And if you've been involved in any sort of implementation of a health IT system that's gone well, you will have done all of those things. What the standards do is provides a form and a structure and consistency. And so what can go wrong is referred to as risk analysis. How bad can it be and how likely is it to be that bad, called evaluation, and what we're going to do about it is referred to as controls. Next slide, please. So as Rudy's already said, one of the key things around this is making sure you got the appropriate subject matter experts involved in the process. Now, one thing that is absolutely stipulated in both of the standards is that top management of the organisation in question must nominate a clinical safety officer. Now, beyond that, there are then some key requirements around what the clinical safety officer must be in order to satisfy the needs of that role. So there's a must that they must be suitably qualified and experienced. And again, that there isn't a stipulation of what type of clinical background it is, and there's certainly a huge value to people who are familiar with a clinical environment or a particular care environment to be involved in as the clinical safety officer for the products are going to be used there. However, if you're not, it doesn't in any way preclude you from doing that work, because coming in with a clear mind and asking sort of simple, naive questions often has a really good power behind it as well. But so you must be suitably qualified and experienced, must be currently registered with your appropriate professional regulatory body. And with that, we do mean clinician and clinical in the broadest sense that all of us on this call, I'm sure, would consider. So it's medical, nursing, dentistry, pharmacy, various different allied health professions as well, of which I'm one. But non-intuitively, it also does encompass social workers, because the standards do apply to health and social care. So social workers registered with the HCPC also can fulfil the requirements for a clinical safety officer, should they also meet the other key requirements here. The third must is you must be knowledgeable in risk management in its application to clinical domains. This might be something that people have previous experience and training in, but also NHS England, we offer a variety of different training courses in order to supplement and to ensure that that knowledge is specific to the use of health IT systems. And Rudy will talk more about those offerings at the end of our presentation. And the final must is that clinical safety officer must make sure that all of the safety processes that have been defined as part of the plan that you will have as part of doing clinical safety in your organisation are followed. So, as Rudy said, this is not a solo activity. There is a nominated clinical safety officer taking the lead on the work, but they should be working as part of a multidisciplinary team, and the overall clinical safety approach is the responsibility of everyone that's involved in the implementation, development and use of the system. Next slide, please. And one more click. So yeah, as I said, multidisciplinary team. It's good to have people from both a clinical and a non-clinical background. Make sure that you've got involvement with people who are going to be representative of the end users of the system in the different clinical environments that they use, so they can give you that real feedback about, will this system work and be able to be used by their colleagues in those clinical areas. Where appropriate, getting involvement of patients as well is highly desirable. And the other key people you'll need will be people with a detailed technical working knowledge of the system, people involved in any business process change that's happening as a consequence or as a desirable outcome of implementing the new health IT system, people involved in training, and all sorts of people involved in the system support as well. So a lot of people need to be involved. One of the other key things with the standards, though, is that they do introduce the concept of proportionality. So the amount of time, effort and resource that is expended on the implementation of a health IT system should be commensurate with the relevant risk profile of the system. So if you've got a highly complex system that's going to be mission critical to all sorts of critical patient care activities, it's going to require a lot of input, whereas you're dealing with something that is far lower risk and fairly simple in its design and functionality, then again, proportionally, you should sort of think about how you scale down the amount of resource that is spent on it. And again, that will be backed up by your clinical risk management plan that will explain your safety approach to a particular product. Next slide, please. So once you've sort of commenced with doing your clinical safety work, you've got all the different people involved, you've got your processes defined, you've got your change of governance defined in your organization, which is really critical. It's important then to realize that all of the evidence that you start to gather around how you do safety and the detailed discussions that you have, all of that body of evidence is your clinical safety case. The clinical safety case, when you look at it, should be an argument which is supported by evidence to support your argument. And again, it should be within the context of how the system has been designed and its appropriate scope of use, and how you're going to use the system in your organization. So that's the overall clinical safety case, your entire body of evidence. A clinical safety case report is a snapshot view of time of key parts of your entire body of evidence that can be produced at a certain point in the life cycle of either the procurement or development or use of your system. That gives us a clear, concise, understandable summary to people of what the product is, its risk profile, and recommendations around continued development or actual continual use, etc. So that safety case report needs to be compelling, it needs to be comprehensible, it needs to be valid, it needs to be up to date, it needs to have all the appropriate evidence. It should be seen as a living document, and new versions or iterations of that report should be used throughout the life cycle of the system to indicate various stages of development or use, and also if there are new versions of the system that come along, or in response to any incidents that might happen that might challenge some of the initial assumptions that were made in the early stages of producing a safety case and a safety case report. And I think that's about it from me. So I'll hand back over to Rudy.
Thank you, Andy. So Andy's taken us through a whistle-stop tour really of the standards, the clinical risk management processes, and some of the documents and activities within those processes. So just to finish off with the incident management process, obviously the activities that you conduct throughout your clinical risk management process should minimise the number of incidents that you get when you go into live. You do need to make sure you've obviously got an incident management process in place before you go live, and it's inevitable that there will likely be some incidents, but hopefully the work that you've done that Andy's spoken about will mean that you can be reactive and manage those incidents. So just talking through this image here, you need to have a way to monitor and detect incidents in live. So one way of doing that is obviously to make sure you've got that clear culture of digital clinical safety and that awareness, you know, across your whole organisation for incidents to be reported. And then the second thing is having a mechanism to be able to report incidents, whether that's Datix or a different system. Then there's the process of analysing and assessing. So has it, for example, been given a clinical safety flag or a tick for clinical safety? If it has, then who assesses that? Does that go to your clinical safety officer? Are there two different risk matrices that need to be considered? The supplier, the one the supplier uses, and your health organisations. So a level of risk will be given at that point. Then you can move forward to tactical management. So is that comms go out to all of your users? So it might be a product alert notice, you know, an example, an admin chart's defaulting to 100 hours and the supplier has indicated a workaround to type administration time, for example. So there's a short-term tactical management of that incident to make sure that patients don't come to harm. And then obviously you progress to root cause analysis, and hopefully that would be working in partnership with the supplier to fix the issue, because it may well be that there's a local configuration issue. It might be that there's a defect in the software. So progress forward through to root cause analysis. All the work that you do during incident management and the incidents that are raised should be fed back through into your clinical safety case report and your hazard log. So the learning from your incident management process should feed into your hazard log. So it might be that some of the hazards haven't been identified, some of these hazardous scenarios, so you need to feed that in to your hazard log. It might be that you need to add additional controls in place to reduce the likelihood of these incidents occurring in future. So it's very much, as Andy said, an iterative process of updating these documents. You may well have a risk and issues meeting once a week, once every couple of weeks, where you just make sure you go through and review the incidents that are coming through. And you've obviously got the final piece that's strategic management. So it might be that detection scripts are run to understand how many patient records are affected. It might be contacting patients. So again, a very quick whistle-stop tour through incident management process. If we can go on to the next slide, I think it's training. So as I say, we've just gone through, cantered through there, the process and some of the documents that you might expect to update. Do we do offer training? I think we'll have probably had quite a few people on this call on our training. So in terms of the point that I made about culture, we've developed an e-learning module that's free for NHS staff called the Essentials of Digital Clinical Safety. So our Chief Medical Officer was really keen and felt it was really important that every single member of staff in our organisation undertook a basic level of digital clinical safety training. So that's why we put this together. So it's really clear, really easy to understand, clear examples of incidents and so on, just to give all staff at your organisation that clear understanding of what role they can play. As Andy said, again, going back to the point about it being a team sport. So I definitely, I believe these slides will be shared. So I definitely encourage you to offer that out to your staff. Again, it's free. So other training that we offer. So for those with more of a direct role within digital clinical safety, we've got the clinical risk management e-learning. It's I believe it's now called intermediate. So that's the next level where you'll understand some of the, where you'll understand some of the activities and how to conduct those activities in more depth. Then we've got a further course that's a practitioner course. So that's for those that are working directly in digital roles. So that might be that you're a clinical safety officer. So the foundation course that we've got, which is going to be called it's now called the practitioner course. That course is for those people wanting to become clinical safety officers. So for the e-learning and for that course, you get your 14 CPD and you get a certificate that you can obviously evidence that you're knowledgeable in clinical risk management to be able to undertake your clinical safety officer role. I'd like to stress with that it's not just for clinical safety officers. There's lots of non-clinicians such as myself that are very heavily involved in the clinical risk management process. I think, Andy, was there anything else from you on training? I'm just trying. Oh, I think there was some. I'm not sure how much time we've got, Andy, but I know there were some questions potentially on the train the trainer model. I could just I'll spend a minute just giving you a really kind of brief overview of the work that NHS England are doing to structure a train the trainer model. So what's happened over time is we've basically the training that we do, that my team do, has ramped up. We deliver about 6 courses a month. So the demand is increasing, which is really encouraging because obviously the message and the culture is getting to be where we'd all want it to be. But the demand is such that we can't train as many people as we'd like to. So we're looking at developing a train the trainer. So there's a team of us who are working to put that together. So the idea is that my central team would train a group of clinical safety officers that work within ICSs, and then they would go out and they would deliver training to their local kind of organisations. So that's something that we're working on now. Comms has gone out on that, and I'm more than happy to answer questions if anybody's interested. Anything else from you, Andy?
The only just thing to mention is that you know, obviously at the early 2020 we had to move all of our detailed training to a virtual environment, and we've developed that over the last few years, but we've now started to go back out on the road, so we're starting to offer now face-to-face training, and we have sessions that you can book into in either Leeds or London, and if there's enough people in an organisation or in an organisation or in a locality that wanted to get together for training, that we can go out and sort of provide that in your organisations as well.
Thanks, Andy. Yeah, and I haven't. You just reminded me by adding that. I haven't mentioned the refresher e-learning that we've got, which is also free. So that's also on e-learning for health, and I've included the link on the previous slide. So when it's sent out, you'll be able to access it. So that just goes over the key principles, but it uses a scenario, so that's free for you to access. And we've also got a community of practice course where we have clinical safety officers and those working in digital clinical safety who all come together, and we have one in Leeds and in London, and we ask for speakers from the community. So for example, our one on the 18th of April, we've got a colleague speaking about the update to regulation for medical devices. We've got somebody, a clinical safety officer, who's a lead in their area, who's putting together networks within the Great North Care record, and we've got a couple of suppliers, and that's really all about networking, sharing best practice, lessons learned, and so on, because from our experience of kind of training people, clinical safety officers, it can be quite lonely in those roles. And another thing that we piloted that I'm currently going through a business case to get made more permanent is digital clinical safety clinics, where we make ourselves as a national team available to book slots with, so that we can go through some of the issues that you're finding on the ground, and we can work through them with you. So that's something that I'm really passionate about, and I hope that we can obviously offer that. But that is everything from me. Andy, unless you've got anything else, we can hand back to the chair.
Yeah, no, just on the very final slide, we've got some contact sort of details for us. So if you've got any other questions or queries, drop a note to our safety team mailbox, where we've got, you know, a team of sort of CSOs and engineers who can respond to those. There's the email address there for anything to do with training, and there's a link to our website, which has got some presentations that have been done at some of our previous community of interest courses, and also templates that you can use for your clinical risk management plans, safety case reports, hazard logs. They're available for you to use if you wish, if you didn't want to develop your own.
Thanks, Andy and Rudy. I've got a couple of questions coming in, so we've got some time now for a Q&A. So we've had people pop their questions in the Q&A box. And for anybody watching, if you do press on the Q&A at the top, you can type in your question. You can see what questions people have put. So the first one then is, you've spoken a lot about training, but there's some questions around what other support is available in addition to training.
Yeah, I'm happy to take that. So obviously there's the digital clinical safety clinics that we're hoping to set up. And as I say, we've just finished piloting that. So that's something that we definitely want to be a regular weekly slot for people to book into. And as Andy just mentioned, there's obviously the email address, and we do respond to any sort of queries. There's also a chat bot that we've got on our website. It's kind of, I think it's quite underused, but we've got the standards within that chatbot. So if you query the chatbot, if you want to know anything about the standards, it will obviously give you the answer. And we've put like heaps of FAQs in there, so that's also quite helpful to use. There's obviously the network, so not necessarily us, but there's obviously the digital health networks, there's the faculty, more kind of regional and local network. Andy, anything else from you on that one?
Yeah, so you broke up a bit there. I'm not sure if it's your end or my end, but yeah, just to mention, so you mentioned digital health networks, and there's a very active clinical safety group there that lots of people asking questions, sharing documentation, sharing examples, and that's a really good, vibrant community that's going there. The faculty that you mentioned, we were quite involved as a team to set up the clinical safety specialist interest group there, and the faculty still run regular seminars, workshops, etc. to do with clinical safety. It very kindly to date, the faculty, I believe, has still made all of those clinical safety workshops free for non-members as well. But yeah, the Faculty of Clinical Informatics is a really good organisation to be linked with. So obviously, it's as the name suggests, it's primarily aimed for clinicians to join as either a fellow or a member, but they're very welcoming of non-clinicians to join as an associate that, and you'll still have access to all of the different meetings and materials, etc. that they run.
Thank you. So the next question then, when a system is live and an incident has occurred, how can we influence suppliers to take on board any issues or any learning?
Andy, do you want this one or shall I take it?
I'll let you take it first because you usually get closer to the incident management than me.
Yeah, so obviously I think it starts at the very beginning, not helpful, so we'll go all the way to the end, but in an ideal world, in terms of procuring systems, you know, going through procurement with a supplier that is kind of very up with the standards, committed to sharing their documentation with you, that's always a good sign. But let's say that that's maybe not happened, and we're at the point where you want a supplier to acknowledge and work with you. There's often communities that are really important. So I used to work for a supplier, and I used to be heavily involved with electronic prescribing meds admin user forums. So I used to, as part of working for the supplier, I used to attend those forums with all the health organisations, and they'd bring their incidents and issues that they wanted to raise as a group, and that gave kind of much more momentum and made the supplier kind of make changes, you know, to their processes, to their hazard log, to, you know, make change requests, for example, because I know there can be issues where is it a fix, is it a change request, and doing that dance is often quite difficult. But yeah, relationship is key. Obviously, NHS England, we have been involved if there's been issues with suppliers. We're not a regulator, so it isn't necessarily our remit, but being those that wrote the standards, we are happy to respond, sending an email reiterating responsibility, and it often does help. So if you are really struggling with a supplier that just will not you know, support you in updating kind of their documentation and kind of complying with the standards, we do sometimes kind of offer support where we can. Andy, I don't know if you want to add to that.
Yeah, no, exactly what you said, and get to know the CSO or the supplier, create, you know, develop a working relationship with them, and really at the earliest possible stage, you know, right up front when you're still, you know, configuring any systems put in, there should be, you know, detailed understanding of how your IT support desk will be working with the supplier's support desk, and making sure the processes are all fed in there, and making sure that where there might be a clinical safety element, then that's flagged up as quickly as possible to make sure that the CSO from the organisation using the system, as well as the CSO from the supplier organisation, are involved in those discussions and the tactical management and the longer term fixes.
Brilliant, thank you. I think looking at time, we've probably got enough time for another 2 questions. So the next question we've got, In general, is the CSO role a standalone or portfolio role? And is there a recommendation across a large organisation?
Oh, it varies enormously. I work with a lot of CSOs where it's their full-time role is I am CSO and I'm working with multiple systems. Also work with some CSOs who, particularly those who are sort of quite senior in their organizations, who have it very much as just one part of it. So it varies enormously. Some organizations have seen some larger trusts with a lot of different implementations, are lucky enough to have a team of clinical safety officers, of whom they share different responsibilities and have different systems that they might be more involved with than others, but there's a pool of that clinical safety resource involved. So it can vary enormously. I think one of the key things to go back to in the standards is one of the other key musts is that top management must ensure that the appropriate expertise and resources are made available to fulfill the requirements of the standards, i.e. to do the clinical safety work. So that needs to be used. And if you've got a role where you're very hands-on with all aspects of being CSO, you need to make sure that your time is protected. If it's something where it is one of many different hats that you're wearing, you need to ensure that a lot of the different requirements are being done by a team around you, but ultimately you're taking responsibility and coordinating all the work that's done. So it does vary enormously as to how much of people's time is spent on the role.
Yeah, the only thing I'll add is scale and complexity of the systems and solutions is really key, because you might have a larger organisation that's got kind of low risk, systems, not many systems, or you've got a smaller organisation with multiple systems of high clinical risk where you need multiple CSOs. So it is really difficult.
Perfect. Okay, so if I just read out one last question, but any questions that we haven't managed to get to, we will answer offline and we'll make sure that they are shared on the website. So I'm just scrolling through the chat now. And then the last question we've got today, the hardest challenge is suppliers stating that they do not need to comply with the DCB 0129. How do you best approach this?
Yeah, so that can be very difficult. Ideally, one of the things that the standards do look at, and the implementation guidance goes into detail, is a section around intelligent procurement. And it's really trying to ensure that at the very first procurement stage, the requirements, your expectations around clinical safety are built into the contracts. So then it's bound down. So again, often though, issues arise where that horse has bolted and you're already in train, and something might have been procured and you're in there. And with that, it is just a matter of trying to highlight and point out organisations' responsibilities by referring to the standards, by referring to the Health and Social Care Act to say, this is, a requirement that you need to do if you're delivering a system that's going to support publicly funded health or social care in England. You must comply with these standards. And as an organisation looking to buy your services or use your products, we are obliged under the standards, under the Health and Social Care Act, to ensure that you are compliant. So if you aren't compliant with the standard, we won't be able to proceed. So it's really around sort of highlighting the issues. It does happen. It's getting less frequent. I think if there are specific issues, then it's something where our clinical safety team can, again, we'll say we're not a regulator for this, unfortunately, but we can help to provide sort of weight to that argument by helping to provide a statement to remind organisations of their requirements under the standards. And yeah, Rudy, anything else to add to that?
There's a flow chart that one of my our senior safety engineering colleagues has actually written out, that just looks at whether a system is in or out of scope. So I'll make sure that that's shared with you as well, because you can share that over, and obviously it's often clear cut. There's some grey areas, and the grey areas are where we could potentially help, but it's often clear cut. So in the first instance, I'd send that over.
Brilliant, thank you. We'll make sure that we get all of the references, everything uploaded to the website after so that you can access it. Back to
So thank you, Rudy and Andy. Lots of information there. My head's buzzing. I don't know about anybody else's, but thank you for that. Now we're going to pass over to Emily Birch, who's Associate Director of Physical Health for Barnet, Enfield and Haringey Mental Health Trust. Over to you, Emily.
Hi Sam, thank you everyone for having me. I'd like to talk to you today about an unexpected challenge that we experienced in our partnership trust, Barnet, Enfield and Haringey and Camden and Islington Mental Health Trust, this last August when we lost all access to our EPR. So just a brief introduction, my name is Emily Birch. Although I'm the Associate Director of Physical Health for BEH, I work across the partnership supporting digital. We don't have a CNIO role at the moment, but I have experience through being a Topple Digital Fellow and currently a Florence Nightingale Digital Scholar, which has meant that I've been able to support the trusts in some of the digital work that we're doing. Next slide, please. Thank you. So just a brief outline around who we are as a partnership and as a trust. So we have one chair, one chief executive and one partnership executive team, but we are two separate mental health trusts. So we've got two separate boards, two separate financial situations set up, though we are working towards ensuring that what we do with one voice, providing mental health services across all of North Central London. So we provide inpatient and community mental health services across a variety of different settings, from prisons through to children, young adults, dementia care, acute services and crisis. We cover around a population of 1.6 million and we've got around 6,400 staff at any one time. Both trusts did have or do have an EPR system. So Rio was implemented in BEH in 2015 and CNI implemented Care Notes in 2015. And it was CNI that were impacted by the cyber attack in August. Next slide, please. So a brief overview of what happened. And I will try and keep this brief because I could probably talk about the incident itself for hours. On the 4th of August 2022, a number of electronic systems across the NHS, not just our EPR, but other services such as 111 and services in social care, were affected by a cyber attack. The provider took all systems offline to mitigate any further risk as they investigated this. And we went to our BCP. Luckily for us, we did have for CNI, they did have their data securely backed up on a local server, which had been updated that morning, but that only gave us access to read-only files up until the point the system went down. The incident, as we became more aware of the incident, it was managed nationally by NHS England, and the impact of this, it was especially because of the 111 impact, the government did also bring in Cobra to help support getting services and systems back online. However, we were advised by the Tuesday, the 9th of August, that the restoration of services at that point may take several weeks. But as I continue telling the story, you'll see how weeks have turned into months, and we still don't have access to Care Notes at the moment. Next slide, please. So how did we respond? So as in all incidences, I'm sure, as in every trust across the NHS, command and control was set up, very reminiscent of our pandemic days, where we had our gold command, silver command, operational leads were brought in, clinical leads were brought in, and we really went into that control state. As I said before, our BCP was active from the 4th of August. The BCP, our business continuity plan, was paper. So all of those Care Notes forms were available in paper format. We had systems such as access to EMIS and obviously our read-only files where we could view some patient data, but it was very limited. And really that business continuity plan in paper was only viable for 24 to 72 hours. I don't think anyone previously had expected an outage like this to last much longer than that. We went around looking at timelines for recovery. So there was a lot of high-level conversations with NHS England, the National Cybersecurity Team, and the system provider to understand how quickly systems would be restored, how long we were going to be managing with this outage, because dependent on that would be dependent on our approach to this particular incident. When it became clear that systems weren't going to be online in a matter of days, we were looking at weeks and then potentially months. That changed our assessment process. So we were looking at what those options could be, what was the risk associated with each of those options, the cost and the speed that we could implement them. So could we continue with our business continuity plan? Was there an interim solution that we could develop and use internally? Did we need to go and look at implementing a whole new EPR? All of these had to be analysed and the risks associated with each of them identified. To do that, we needed to look at our systems requirements. So we did review what Care Notes had previously, the system requirements that we'd previously had for Care Notes. We also reviewed and did a piece of work with our clinical staff on the ground around what they needed right there and then to make to be able to deliver care in a safe way. I think one of the things to emphasize is, you know, within mental health, a lot of the work that you're doing is associated around understanding and knowing a patient's history. When someone comes into an acute environment or is in crisis, they may not be the best historian. You may not have access to the information that you need, and data flowing into primary care systems and may not always be accurate. So it was really important that we found a way to be able to give our staff the historical information and risk assessments and data that they would normally use to make their assessments and care decisions of care for their patients available as quickly and safely as possible. And that helped us to prioritise. So it helped us to prioritise what we needed to look at. So we stopped all sort of data reporting through to nationals. So one of my other roles is looking at vaccinations and obviously the reporting on things like vaccination data and KPIs, all of that stopped. We were solely focused on how we deliver that patient care and what priorities in the system that we needed to create a safe environment for staff and patients. Alongside that, obviously, we needed to do an assessment, clinical digital safety assessment. So it was looking, as obviously you've previously heard, that whatever we put in, whether it's an interim solution or a longer term solution, was that going to be digitally and clinically safe to do so? And to do that, we needed to create a risk log. Interestingly, obviously, all trusts will have ways in which they report clinical risk. One of the things that we did quite quickly for this particular scenario was change the way that we looked at risk across the trust at that point in time. So it was focused on digital, so we could try and establish what risk was associated to systems, what risk was associated to normal practice, and there were so many unknowns. So we developed a MS Forms instead of using our normal Datex, because we felt Datex would not really capture the information that we needed to put into our risk log for these assessments. So we created a short MS form that allowed staff to just put in a detailed explanation of the challenge they were coming across or the risk they think they'd identified, that could be sent through to the CCIO, myself and other team members to help us be able to sift out what was an immediate digital and clinical safety issue, what was medium long term, and what may be just normal practice that we needed to improve upon. Next slide, please. So just a bit about our leadership and governance. Although I said we set up our command and control, it was very much like the pandemic. We did iterate this to make it suitable to cover the complexity that a major EPR outage gave us. So obviously we were dealing with the here and now, but we also had to be thinking about restoration. So systems that we were bringing in, how were we going to recover that data and migrate it over to whatever system we eventually chose. We had at this point very, very quickly developed a SharePoint outage solution. This innovation came actually from the nurses in our wards, where they started to use SharePoint to gather and create forms that were very similar to care notes, that they could then share that information with each other and document it all in one place rather than multiple bits of paper. So what we looked at doing was making sure that we had an EPR working group, and that was split into 3. So we were looking at pre-outage, what we needed to do around data recovery, data migration. We had our option 2, which was looking at the quick development and implementation of our SOS solution, and what other MS tools we might be able to use at that point in time. And then we had option 2, which was our Rio project. So what we had quickly established was that we were going to need to implement a interim EPR. So the SharePoint outage solution wasn't an EPR and wasn't stable. It was a better solution than doing things on paper, but it was only going to last a couple of weeks. Probably not not longer, because SharePoint wasn't built as an EPR and wasn't built for the level of data and information that we were implementing every day. So we had those 3 working groups, and overseeing all of that, as well as the command structure, we did have our deputy CEO overseeing a governance EPR group, and this reported into our quality and safety board. We needed this to make sure that the whole project and everything that we were doing was in line, did feed into quality and safety, and that we had that assurance and governance, and we had some of that oversight there. Next slide, please. So developing our systems at speed. So as you can see from the dates on here, we had we initiated our BCP on the 4th of August. Obviously there's very few boxes on here, because actually it's really difficult to try and timeline absolutely everything that happened. But by the 19th of September, we had gone live with Rio. That decision only was made on the 9th of September, so we went live with an EPR within 10 days of making a final decision, which took a lot of resource and challenge. So as I said before, we were working on our SharePoint solution. We had to really start to articulate what the risks were around the SharePoint solution and what the next steps would be. So could we wait it out for care notes to come back online? Did we need to have an interim EPR? What do those risks look like? And we presented that to the board. We also realised quite quickly that we needed to keep some really clear, strong documentation going. So making sure that we had a standard operating procedure for the interim solution, SOS, and that there were technical guides and training published, so that there was one place for staff to go to understand what they needed to be recording, where they needed to be recording it. And that also then supported our recovery strategy as well. So we needed to be able to ensure that where we were documenting and how we were documenting would then support that data to be migrated over to whichever system we then chose. By September, it was very clear that we needed that EPR. We needed something to support us more long term while we were waiting for care notes to be recovered. And this is where the partnership really came into its own. Barnet, Enfield and Haringey obviously used Rio and had a lot of the forms and the requirements that C&I needed already in place, and we were able to draw on those resources and draw on that relationship to work with Rio to essentially provide a dummy version of BEH's Rio into C&I. So we were able to provide the pre-configured forms that BEH were using for C&I to use, and that really supported helping that go live date. Next slide, please. So what was the impact? Obviously, you've heard me talk about the challenge in mental health and how that historical data is really important to make sure that you're giving safe and effective care and interventions for our patients. But the impact was much wider. So we had challenges with our patient and flow. So, you know, we have our patients move from our acute services into community and back and forth, sometimes quite frequently, and the information couldn't flow with the patient. So the challenge of a simple discharge and a discharge letter going somewhere was we couldn't provide it, not with our BCP particularly easily, and SharePoint also offered that challenge. We had reduced functionality and visibility of patients and caseloads. So we were really reliant on the staff on the ground, essentially inputting individualized, basically updating all of their patient caseload into this system. And what we realized quite quickly is that wasn't possible for all of our services. Our substance misuse service, for example, had around 1,600 patients on their caseload, and there was no way that the staff had the resources or the time, while focusing on trying to still deliver care, to begin to re-upload information and demographics around their patient caseload. We also really struggled to figure out how we were going to ensure safety alerts and safeguarding was visible. We have alerts on risk, so suicidal risk, risk of violence, and all sorts of other alerts, as well as things like medication and allergies. And how are we going to make those visible? Where on the system could we make that clear for staff to see and act upon? Because that was all lost when the EPR went, and we were having to essentially redo everything. There's also something around the workforce. So this is a workforce that was coming out of the pandemic, that had just been through a really challenging time delivering care in a high pressured environment, and now essentially we were working in the dark. And we were also very conscious on whatever decision we were making, whether to move to an interim solution, a longer term EPR, or waiting out for care notes. There'd be a challenge with change fatigue, you know, a challenge with asking staff to relearn multiple systems in a very, very short period of time. As I've alluded to, this also created a lot of manual workaround, and that was a huge demand on our workforce, when really we wanted the focus to be on delivering care to patients rather than inputting data into a system. We also had an inability to report on clinical data and audit for assurance. So as I said, we had to pause all reporting KPIs and data to national teams, but also that meant internally, so how we would normally manage our risk and how we would normally identify issues and get assurance, those disappeared, and we had to quite quickly think of alternatives. And the data management side of things. So when we found we lost that EPR and we inputted our SharePoint solution, there were challenges around things like accidental deletion. You know, it wasn't an EPR. We did have an incident where a member of staff accidentally managed to delete all data from SharePoint. Luckily, we did have a recovery system in place, and we could recover that data up to 90 days. But obviously, at that moment in time, that's quite a scary thing for staff to be managing, and also something for us as a risk to be very aware of, that we could be losing data unintentionally, and that by using multiple systems, it might be unclear as to how to manage a patient. So if you're using multiple systems and inputting data in lots of different places, you're not then going to get that whole picture of the patient and then be able to make the right clinical decision for their care. Next slide, please. So these are probably the main patient and clinical safety concerns that we focused on, and I've talked to some of these already. I just want to highlight a couple of them. The decision making, for example, how we came to the decisions that we did as a senior team, as an executive team, was reliant on understanding these risks here. But there was also a moment where holding off on making a decision was becoming just as challenging as trying to make a decision when you don't have all of the information. So not knowing that restoration for care notes presented a real patient and clinical safety concern for us. We needed to be able to have something stable, an EPR or something to deliver and record our information on for our patients. And the pause and the holding and the anxiety around making a wrong decision was just as much of a concern as
Sorry, Emily, we've lost your sound.
apologies.
That's
I'm not quite sure what happened there. Obviously the workforce and the comms, so communication as well, how we communicated during this also raised a few patient clinical concerns, making sure that everyone had the right information at the right time, making that information clear and accessible and being transparent around what was happening, and understanding what the workforce was doing and understanding what our services were doing so that we could then make sure that they had the right information to deliver the care that they needed. We had some real concerns around certain areas of care, such as the Mental Health Act, safeguarding and substance misuse. These areas weren't suitable to be set up on our SharePoint outage solution. So how were we going to manage that risk? And also resources. So although we were able to lean on the partnership, we didn't have any additional money or extra resources necessarily to deliver all of these, to deliver a whole new EPR in a very short period of time. So that became a risk we needed to mitigate. Next slide, please. So how did we mitigate some of these? So one of the things that we were very clear on, and our CIO was very, very clear on, was that this needs to be a clinically led response. And that clinically led response informed our digital and technical teams. We needed to understand very clearly what our services and what our staff needed to do their job, and how could we make it as simple as possible for that to happen in as safe as way. Our CCI was supported to temporarily step back from her clinical work so that she could lead that response. And so she was full-time working as a CCIO purely on delivering this piece of work. And this is where my role came in as well, supporting in a partnership. So I was able to put aside a few pieces of work in my normal day job and make sure that I was focusing and supporting this outage. QI methodology and leadership was a really important way for us to be communicating and working with our staff. Our QI team are absolutely fantastic. They did a piece of work where they processed, mapped all of our services, and they delivered the training, and we framed it as a QI piece of work rather than a digital piece of work. So we made sure that the language we were using, staff were able to understand. That also took some of the fear away. As I said before, we made sure we had a new way of reporting risks so that we could in real time react to those risks, put in immediate changes, or understand what needed to happen next. And obviously the development of our clinical systems, working with our key stakeholders to make sure that we understood what hotspots were really important as well. Next slide, please. So a few reflections on some of this was the importance of network. So I am blessed to be part of the Florence Nightingale scholarship at the moment. So I had a team of CNIOs and previous Digital Florence scholars that I could call upon to help understand and work through some of the issues that were coming at us at a very, very quick and intense time. We also have we had some pastoral care from other CCIOs across the system to help us work through what we needed. Really, really important to actually have that digital leadership in the trust. Without it, it would have been very, very difficult to articulate the risks and make the decisions. Communication, when we did it well, it was great, but it can also backfire on you if you're not clear on what you're communicating or doing it in a timely way. And the language that we used was really important. So when we were talking about safety, we needed to be very clear on what we were talking about, to try and reduce fear and make sure that we were getting clear actions from that. There was also a point of not being afraid. So at times when we were not making decisions, or when we were thinking about going live so quickly, we needed to be clear that sometimes you need to stand up and say, I'm not sure we're ready to go yet. There are certain areas that we need to tick off first. Do we need to pause what we're doing, or do we need to go quicker? Don't be afraid to use your voice, and realize that there's opportunity and learning from this. So it was great to see that we could move forward and more strategically to think about standardized forms across both trusts, rather than us using different types of risk assessments. And it's a team job. Be kind and work as a team. Next slide. Just to finish up quickly on our key learnings so far. As I've said, clinical leadership is essential. Decision making, no decision is just as risky as making an ill-informed decision, and making sure that you understand the priorities of your clinical teams and what they need to do and how they need to do it is a great way to understand what systems need to be in place. And actually, maybe we don't need 350 forms on our EPR. Maybe you just need to keep it simple. And collaborating with those around us was one of the biggest things that we needed to do to make sure the right voices were in the right room to get the answers that we needed to move forward. Next slide. We are still in an outage at the moment, and we are still working on implementing Rio as an EPR. So we're also going through a procurement exercise at the moment to look at what that strategic EPR could look like. We have a Rio prioritization group that helps us switch on forms in a 2-week format, so that we're not overwhelming staff. But just to leave you with a key bit of information, an interesting fact, on that first day of go live of that EPR, after 10 days of deciding when we were going to implement Rio to when we did it, we had, out of 1,500 staff, we had 729 staff successfully log in on that first day of go live, and we had 3,230 progress notes implemented on that first day of go live, and we've been moving forward ever since. Thank you. Next slide. If there's any questions or you want to contact me, my details are there. I realise that's a really whistle-stop tour, and apologies for going over my time.
Thank you, Emily. It was really interesting, actually, and I think a lot of us may be coming to you for help when we do EPR procurement. Unfortunately, we are out of time, so all the questions in the Q&A, if you can answer as we go along before the call closes, that'd be fantastic. We don't have time actually to answer them live at the moment. So thank you everybody for joining us for our session. There will be an evaluation which will be shared. If you can complete that for us, please, and sign up for the next session, which is on the 9th of March, of supporting nurses, and that link will be shared as well. So I'd like to say thank you again to Andy, Rudy and Emily for being wonderful speakers and making us all have a big thought in our heads of what we need to do next. Thank you.